Bismillahirrahmanirrahim. My name is Dr. Zaid and I'm Assistant Professor of Pulmonology, Kajafan Medical College, Sawabi. Today we will start some topics of pulmonology which will be covered in fourth year. There will be 4 lectures of pulmonology in fourth year. In this first lecture, we will briefly discuss the pulmonology and basics of pulmonology. What is pulmonology? Pulmonology is the study of diseases of the chest and its management and treatment. Learning objectives of these presentations are at the end of this presentation, the fourth year students should be able to enumerate the various symptoms of respiratory system, interpret the pulmonary function tests. What do you mean by symptoms? Symptoms are what the patient tells the doctor, with which patients come to the doctor. Those are called symptoms. And what is sign? Sign is what the doctor sees in the patient. For example, if a patient with chest diseases comes to the doctor, chest OPD or clinic, and complaining of cough, difficulty in breathing, fever, chest pain, these are called symptoms. And when the doctor examined the patient and saw, he or she see the patient that he or she has bluish discoloration of the lips or tongue, so it means he has sinus or he has raised respiratory rate, so he has tachypnea. So cyanosis, tachypnea, these are called signs. So everyone should be clear about symptoms and signs. Okay, now we will move on to the respiratory symptoms. What are the respiratory symptoms with which patient comes to the doctor? One is cough. In each symptoms, the onset of symptom is important. Certain things are very much important. For example, onset, duration, progression, aggravating and relieving factors. These are important. For example, if the patient comes with a cough of less than 2 weeks of duration, then we will think of, and the doctor will think of, acute respiratory illnesses. But if the patient comes to the doctor with a cough of more than 2 weeks of duration, so the doctor will think of chronic respiratory illnesses. For example, in acute illnesses, cough less than 2 weeks of duration is, he may think of pneumonia, respiratory tract infection, and in chronic, he may think of tuberculosis, malignancy, bronchitis. So the onset, severity, relieving, exacerbating, and associated factors are important. Similarly, sputum is another symptom of respiratory diseases. If a patient complaining of sputum for more than years, for more than 1 year, so he or she may be suffering from bronchitis, and amount is also important. If a patient has scanty and episodic sputum, so he may be suffering from asthma or COPD, especially chronic bronchitis. But if a patient is complaining to you and says that I have sputum about a cup or a glass per day, and this is for the last so many years. So you will think of bronchitis. An acute illness, if a patient is complaining to you that he has sputum for last 1 to 3 weeks, so you will think of lung abscess. Similarly, hemoptysis. Hemoptysis is blood in the sputum. So this is important to know the amount of blood in the sputum as well. Chest pain. Chest pain is maybe due to cardiac causes or lung causes. We are talking of lung causes. If a patient complaining of chest pain, acute and onset, and just happen and comes to you, then you will think of pulmonary embolism or pneumothorax. But if a patient is complaining to you of chest pain for more than a week or months, so he, you will think of chronic diseases. Okay, shortness of breath or difficulty in breathing. This is very important to rule out causes of dyspnea or shortness of breath. If a patient is breathing during walking and he may be uh, stable at rest, so most probably he has some cardiac causes or may have lung causes as well. Also, if he has leg swelling with shortness of breath, so maybe he has heart failure or core pulmonary. Wheezes or whistling sounds, and fever. Fever is another important symptom which is present in infection and infarction, maybe in pneumonia, bronchitis, lung abscess, and in some malignancies like lymphoma. Weight loss and night sweats are important because sometimes patient complaining to you that I have drenching night sweats के रात के वक्त मेरे कपड़े गीले हो जाते हैं, इतना ज़्यादा पसीना आता है. So you will rule out lymphoma in this case or TB. Another topic is pulmonary function test. In this image, this is the patient and this is the technician and this is the recording machine, and this instrument is, this is the spirometer. This is called spirometer, and this is the nozzle clip. Patient takes deep breath and blows as hard as possible into the tube, and this machine records the readings. In the technician, what is the role of technician in this test? Technician monitors and encourages patient during the test. So here we will discuss the total lung capacity, the residual volume, the functional residual capacity, inspiratory residual volume, expiratory residual volume, vital capacity, force vital capacity, and slow vital capacity, and force expiratory volume in first second. Now we will discuss it one by one. Total lung capacity. This is the total volume of the lungs when filled with as much air as possible. मतलब कि पेशेंट या नॉर्मल बंदा जितना इनहेल कर सकता है मैक्सिमम, एट द एंड ऑफ inhalation, the capacity of lung is called total lung capacity. Okay. Force vital capacity. This is the amount of air exhaled forcefully and quickly after inhaling as much as you can. It means that after maximum inhalation, when the person forcefully exhale this air as much as he can, so this is called force vital capacity. FEV1, force expiratory volume in first second. This is the amount of air exhaled during first second of expiration. अगर हम पीछे देख ले, यहाँ पर फोर्स वाइटल कैपेसिटी में फर्स्ट सेकंड में जितना एयर एक्सहेल हुआ इस फोर्स वाइटल कैपेसिटी, उसको FEV1 कहते हैं. Peak expiratory flow rate. This is measured by peak flow meter, a small instrument which is present in our ward OPD. Sometime we use it and sometime we give it to the patient, and he or she will record the peak expiratory flow rate at home during morning and night, and will come after 2 weeks. This instrument or this test can be used for the confirmation of asthma as well. This is the fastest rate that can force air out of your lungs. Tidal volume. This is the amount of air inhaled or exhaled during normal breathing. जब इंसान रेस्टिंग पोजीशन में हो और वो जितना एयर अंदर इनहेल करता है और या एक्सेल करता है रेस्टिंग पोजीशन में, सो दैट इज टाइडल वॉल्यूम. Vital capacity. This is the amount of air that can be exhaled after inhaling as much as you can. Okay, this is easy. ये आसान है क्योंकि फोर्स वाइटल कैपेसिटी का हमें पता है कि बंदा मैक्सिमम इनहेल करे, मैक्सिमम इनहेलेशन के बाद जितना वो एक्सहेल कर सकता है, ये मैक्सिमम एक्सहेलेशन को वाइटल कैपेसिटी कहते हैं. If this exhalation was done forcefully, that is force vital capacity. If this exhalation was done slowly, that is called slow vital capacity. So now we will discuss the functional residual capacity. This is the amount of air left in lungs after exhaling normally. जब हम नॉर्मल इंस्पायरेशन करते हैं, एक्सपायरेशन करते हैं, और उसके बाद लंग के अंदर जितना एयर रह जाता है, सो दैट इज कॉल्ड फंक्शनल रेजिडुअल कैपेसिटी आफ्टर normal exhalation, not forceful or maximum. In residual volume, this is the amount of air left in the lungs after exhaling as much as you can. What is the difference between functional residual capacity and residual volume? In residual volume, this is the volume left in the lungs after maximum exhalation, while in functional residual capacity, that is the volume of the lungs, of the air in the lungs after normal exhalation. Okay, you have seen this image in your physiology textbook. Here on one axis, one side there is volume in liter, and on the other side this is time on this side. Here you can see normal inspiration at resting position. That volume is called tidal volume. And after normal maximum inspiratory volume, that is called, if we inspire maximally after normal tidal volume, then that is called inspiratory reserved volume. The combination of tidal volume and inspiratory reserved volume is called inspiratory capacity. And what is vital capacity? If we inspire maximally, this is the point, inspire maximally. After maximal inspiration, the amount of air exhaled as much as you can. So this is called vital capacity. If we, if the patient exhale this air slowly, this is called slow vital capacity. And if the patient exhale this air forcefully, so this is called force vital capacity. And what is the, this is the total lung capacity, the total amount of air left in the lung after maximum inhalation. That is called total lung capacity. This is the residual volume, the amount of air left in the lung after maximum exhalation. This is maximum exhalation. And what is functional residual capacity? Functional residual capacity is the amount of air left in the lung after normal exhalation. This is the difference between FRC and residual volume. One is normal exhalation and the other is forceful maximum exhalation. Now we will move on to the interpretation of PFTs, pulmonary function test. This is very much simple. If you learn these 2 points at this stage, this will be enough for you. One is obstructive airway diseases, other is restrictive airway diseases or restrictive lung diseases. We divide obstructive and restrictive lung diseases on the basis of this ratio FEV1 by FVC, force expiratory volume in first second by force vital capacity. If this ratio is less than 70% of predicted, so this is obstructive airway diseases. And if this ratio is more than 70% of predicted, so this is restrictive lung diseases. And this ratio can be more than 70% in normal patient. In that case, we will look into the FVC, force vital capacity, and FEV1 alone. Okay. This table shows the causes of obstructive and restrictive lung diseases. Simply, if you learn the an obstructive lung diseases, asthma, COPD, and bronchiectasis, and restrictive lung diseases, chest wall abnormalities. These are the causes of multiple causes of chest wall abnormalities. Some medications which are used for prolonged duration may cause fibrosis and interstitial lung diseases and neuromuscular disorders. These are the causes of restrictive lung diseases. We divide the we classify the severity on the basis of pulmonary function test, and we look into the FEV1, force expiratory volume in first second. We divide into mild, moderate, moderately severe, severe, and very severe. If the ratio, if EV1, not the ratio, if EV1 is more than 70%, so the obstruction is mild. If that is between 60 to 69% of predicted, then the obstruction is moderate. And if that is between 50 and 59, it is moderately severe. And if that is between 35 to 49, that is severe. And if less than 35, so he or she has very severe obstruction. This is an image of a patient of pulmonary function test which was done at or OPD, just OPD. This is the flow volume curve and this is the flow time curve. Here in this, you can see the biodata of the patient, which is name, date of birth. We will add these things, smoker or non-smoker, what is the age of the patient, the gender of the patient, the height and weight, and the BMI, basal metabolic index. And here we can see the FEV1 and FVC, and this is the ratio. When we put these finding or this data into the computer, this will give the predicted value to us that the patient should do at least do these FEV1 or FVC. And this is after blowing the air into the tube of the spirometer, the recording comes. Here you can see the patient should have done like this. This was the upper limit for the patient. but the patient has done more than this. So that's why the patient, if EV1 is 112% of predicted, it means the patient has no lung restriction or obstruction. And here you can see the report, which is normal spirometry. This was all about the basics of the interpretation of pulmonary function test and the symptoms of the chest diseases. Thank you. السلام عليكم استاذ بي تاسو له ما انتظار وکړو خپل مې ریکارډ کړو نه ما خو ښه